Hello, let us continue with our session on microbiology test for rapid, early, and accurate. The issues with molecular diagnosis is that often it becomes like a blind testing. Then over testing is an issue. The cost of molecular diagnosis is a challenge. Then interpretation challenges are another issue. The advantage of the rapid molecular diagnosis access is that directly from the culture bottles, the molecular testing could be done, and it takes just 1 to 2 days for the results. For example, nucleic acid amplification test, the identification and the resistance markers takes about 1 to 3 hours. Pre-molecular testing, that is from the subculture colonies, it takes about the identification and the sensitivity testing takes about 24 to 48 hours. So molecular testing offers this using 1 or 2 days early than this culture and sensitivity results. We have nucleic acid amplification testing for direct detection and resistant markers, which gives the direct testing results within 2 to 6 hours of the culture colonies. What are the different rapid molecular diagnostic assays that are available? We have cross-defined tool PCR, which can be used either as standalone test or as part of multi-step test algorithm. Then we have multiplex PCR for respirator panels, for gastrointestinal panels, for microbiome tuberculosis. Then we have multitude of whether it is metric acid, laser detection, ionization, time of flight, mass spectrometry of organism record on solid media. Then we have multiplex PCR for meningitis and sepsis. We have multiplex PCR for gastrointestinal panel. We have multiplex PCR for lower respiratory tract as well as upper respiratory tract panels. There are different molecular assays for non-broad streams as well as for bloodstream infection. Mild of mass spectrometry of organisms record on solid media after subculture from blood culture bottles are available. Then we have multiplex PCR, we have microarray testings also, we have mild of available. Then we have rapid follicular in situ hybridization tests, we have magnetic resonance, then peptide nucleic acid fluorescence based in situ hybridization are also available for the diagnosis of bloodstream infections. Now, what are the challenges? Over diagnosis. False positives can occur because of contamination. It cannot differentiate between live and dead organisms. False negatives can occur due to viral genomic shifts and drifts, and also because of PCR inhibitors. PCR is an easy thing to do badly. PCR is polymerase chain reaction, and the likelihood of waste contamination or data misinterpretation from poorly executed molecular tests are the nightmares of even the most forward-thinking diagnostic advocates. You can refer to the details of PCR in the journal National Revision Microbiology. Then evaluating appropriateness and diagnostic stewardship opportunities of multiplex PCR within a hospital system. This is a very good interesting article. You can refer to the therapeutic advances in Infectious journal for the same. The frequency of use of the for the GI panel has been increasing. The identified pathogens from the GI panel includes Vibrio, Astrovirus, Giardia, Yersinia, Pseudomonas, Adenovirus, and others such. Most common is the Clostridium difficile toxin that has been identified for the E. coli, norovirus, intra-aggregate E. coli. But inappropriate use is a challenge for the molecular test. So cartridge-based test as molecular diagnostic assays for diagnosis of infectious disease. Then the chip-based systems also. All antigen and antibody assays are banned for diagnosing tuberculosis because of high variable sensitivity and specificity. Now, PCR versus microvirus depends upon the spectrum, the targets, the sample of choice, and the interpretation and the impact on therapy. Rapid detection of resistance gene within the few hours that helps in making the decision to use more specific antimicrobial agents rather than the broad spectrum agents are the advantages of rapid molecular diagnostic assay. They provide fast results leading to reduced time to effective therapy, mortality risk, and length of stay. Then interpretation challenge leading to overdiagnosis is an issue. False positives because of contamination is an issue. Molecular tests cannot differentiate between live and dead organisms. False negatives can occur due to viral genomic shifts and drift PCR inhibitors. The large proportion of inappropriate tests. There is a need for enhanced diagnostic stewardship. Restrictions on timing of test ordering, related to hospital admission, and repeat testing is a requirement. Given a dynamic and advanced landscape of rapid diagnostics, continue to clinician education by stewardship teams. Then there needs to be done to ensure appropriate interpretation, ensure optimal antimicrobial use based on testing results. Microbiology laboratory is pre-assured to perform exhaustive, expensive, and clinically relevant testings, which when misguided misleads the physician into erroneous diagnosis and inappropriate therapy. Diagnostic stewardship is essential to prevent such irrational testings. Good communication between the treating physician and the microbiology laboratory for optimal diagnosis and treatment of the patient is required. Means should be in place to reduce unnecessary testings and diagnostic errors. The take-home message is advice to the physician regarding appropriate sampling and the test request match. Selection of the rapid diagnostic tests that are most relevant to clinical practice is a requirement. Rational testings may improve infection management and antibiotic prescription behavior. Timely and accurate microbiology results is a key for effective management of the patient care. Then improved communication, reporting of the results to clinicians to influence their infection management and antibiotic prescription behavior. That's all from the session of rapid test. Thanks.